This video will cover how to approach hypotension. For overview, we'll briefly look at physiology, define hypotension, talk about the medications we'll use for hypotension, look at the actual approach, and then just some finishing notes. For the physiology review, we're going to look at this from a hormone site and the receptors they activate, because that's what the medications that we carry and that we're going to use to fix hypotension. So let's look at endogenous catecholamines. What that means is endogenous means that the body makes it naturally, and catecholamines is just a class. So in this case, we're looking at epi, norepi, also known as Levophed, and dopamine. There are other endogenous vasopressors the body makes, but we don't have access to those medications at HGH, so we're not going to talk about it in this video. So for the receptor sites, just very simplified, there are alpha receptors, which are located on the the vessels. Those make vasoconstriction. They make the vessels smaller, which increases systemic vascular resistance. For the beta 1, that location is in the heart. That's going to increase inotropy, dromotropy, and chronotropy. And that just means it's going to make the heart beat faster and more forceful. Before we define hypotension, I want to first look at blood pressure operation and MAP. So for blood pressure operation, we're looking at the entire circuit. So the heart and all of the blood vessels. How blood pressure actually operates is when the left ventricle contracts and ejects the blood from left ventricle into the aorta, it creates a really high pressure in the circuit in the aorta. And so what the blood does is it simply moves along this concentration gradient until it's even. So if the aorta is the really high pressure side, then in the right side of the heart, in the right atrial right ventricle, it's very low. So the blood moves forward towards the right side of the heart through the circuit, moving from high pressure to low pressure until it's even. Next, MAP. MAP is mean arterial pressure. Mean simply means the average. In the case of MAP, we're looking at the average of time. So let's look at that. Look at the equation first, and then we'll talk about why. So the formula is diastolic blood pressure multiplied by 2 plus systolic blood pressure, and you divide that by 3. Why? Well, in the cardiac cycle, it spends 2/3 of the time in the diastolic phase and only 1/3 of the time in the systolic phase. And this makes sense, because if it were to beat and then beat again, it wouldn't have time for the blood to move along that gradient and move the blood forward. So it beats, creates that high pressure, the blood moves along the gradient forward towards the right side of the heart, moving the blood. So it needs more time in the diastolic or the rest phase in order to move the blood. So when we're averaging this, and it's spending 2/3 of the time in the diastolic phase and only 1/3 of the time in the systolic phase, that makes sense why we do 2 diastolics and 1 systolic, and we divide by 3 to get the average or the mean pressure over that amount of time, in this case, 1 cardiac cycle. Okay, now that we've done all that, we talk about definitions. It's very simple. The minimum MAP is 65. We're looking for no lower than 65. Yes, of course, there are always exceptions to this, but in general, when we're talking about hypotension, we're defining that as a MAP less than 65. The 2 drugs that we'll be using to treat hypotension are epinephrine and norepinephrine, also known as Levophed. Even though these drugs are very similar, I want to highlight the differences. First, Levophed. Levophed is predominantly alpha, meaning vessels, with some beta, meaning heart. So it has more vessel action than it does heart action. Conversely, epinephrine has more heart action, predominantly beta, than it does alpha, or vessels. So Levophed, predominantly alpha, epinephrine, predominantly beta. We'll expand more on when to use these later in the video. For medications, EMS is only going to carry epinephrine and Levophed. Let's talk a little bit about the dosing ranges. We give you a range here to give you some guidance, but understand that those are not the true maximums. The maximum of the range is actually receptor saturation. And so just a quick analogy here. Let's say you had 100 epinephrine receptors and you were at 10 mics, but only 50 of the receptors were filled. Well, then you have more room to increase until the receptor saturation is complete. Once you have receptor saturation, adding more medication doesn't have any effect. So just a short little example. Let's say we're at 10 mics a minute and we've had a good increase from 8 to 10 mics, but we're not quite at our goal. And we go to 12 mics and then we're at 14 mics. And there was no change going from 12 to 14, maybe go from 14 to 16, and no result happened again. That would be receptor saturation. That means that we're just increasing the medication with no effect to pressure. That's likely that the receptors are all saturated. Okay. Next, for preparation, we are only going to mix this epinephrine 1 milligram in 250. And for Levophed, we're only going to mix it 8 milligrams in 250. Under the EMS tab in the pump, these will be the only options for mixture. For the approach, we'll go through this stepwise approach and then we'll look at an algorithm-based treatment pathway. So for the stepwise approach, the first thing you have to do is confirm that it's actually hypotension. You do that with a manual blood pressure. The monitor is notoriously unreliable, so we gotta confirm with the manual pressure. We don't want to start pressors on somebody or give them a ton of fluid when they're actually normotensive. Next, if ACLS is indicated, follow that. If they're hypotension and the heart rate's 30 or 200, follow ACLS. Don't start pressors necessarily. Third, so we confirmed it's a true pressure with manual, it's not ACLS, and we have symptomology. Number 3 is symptomology. Let's go through it. So blurred or fading vision, dizziness or lightheadedness, fainting, fatigue, maybe they have trouble walking when they're normally able to, trouble concentrating, nausea with or without vomiting. These symptoms are going to be variable based on the degree of hypotension. Meaning, if the pressure is really, really low, MAPS in the 20s or 30s, they're probably going to be unconscious. But if the MAPS borderline may be 50, 55, they may just be really fatigued. We have to assume that this symptomology is caused from the low pressure. I want you to think about it as the whole saying of it's cardiac until proven otherwise. If you have hypotension and they are symptomatic, the cause of that symptomology is the hypotension until proven otherwise. This is the hypotension decision tree. It's an algorithm-based format to help with ease of use. All right, so for the first junction here, we have peri-arrest and not peri-arrest. Peri-arrest simply means that they are about to go into cardiac arrest. First, we'll look at the peri-arrest side. Example of this would be someone that is unconscious, unresponsive with a very low blood pressure, maybe MAPS in the 30s or 40s. For this group, we are going to immediately push dose on them. If they improve, that will lead you towards an epinephrine drip. If they're unchanged, repeat the push dose, increasing the dose. And if they get worse, I want you to do a 250 ml bolus up to 2 times under a pressure bag to get it in quickly. Okay, back to the top. Not peri-arrest. Not peri-arrest are people that have a low MAP, but have the symptomology we talked about before. So unable to ambulate or confusion, that sort of thing. There are 3 legs in this group. One is requires fluid, withholds fluid, or unknown etiology. We're not really sure what's going on, kind of the gray area. First, let's look at the required fluid side. Required fluid example would be somebody who is septic. Maybe pneumonia that wasn't treated, has now jumped into the bloodstream, and they are septic. And we go ahead and load with a 30 ml per kg bolus, again, under a pressure bag to get it in quickly, and then go to utilize the Levophed drip. For the withhold fluid side, this is the cardiogenic shock patient or the CHF exacerbation patient. They will get worse if you give them a lot of fluid. So first thing we're going to do is we're going to do some push dose epi, maybe a little smaller dose, 5 or 10 mics. And if they improve, again, epinephrine drip. If it's unchanged or they are worse, let's go ahead and try the 250 ml per kg bolus, again, under a pressure bag to see if they improve. Please learn this decision tree. This will help guide you on these calls. Anytime that you're going to administer vasopressors, I want you to administer calcium chloride. Calcium is a positive inotrope, means that it's going to increase the force of contraction. If you want to know more about this, look up electrophysiology or cardiac electrophysiology, and you'll see that calcium is basically everything in that cycle. So, hypotension treatment for using calcium, we're going to give 1 gram over 2 minutes anytime that we're going to administer pressors. Some finishing notes. We are going to remove dopamine from the HGH formulary. It'll be out of the protocol. It will no longer carry the medication. Next, hypotension is an emergency. Please treat it as such. Learn the decision tree so that you can utilize it when you run into these calls. Some expectations. Please mix push dose on these calls so you're ready to utilize it when you need it. Practice with the pump in your downtime so that you can be quick about getting these drips started. And again, learn that decision tree. It'll help guide you on these calls. Lastly, a reminder here is your body makes epinephrine and norepinephrine. It only has a small amount of storage, if you will, and it makes it very slowly. So if we're giving these medications or there's a need for us to give these medications, it's just because you've run out. Yes, these are dangerous medications and bad things can happen, but just know we are just replacing the deficit that your body has. The last thing we'll review in this video is I want to look at the stepwise approach again. Number 1, confirm it's actually hypotension using a manual pressure. 2, follow ACL if it's indicated. And 3, use the decision tree. It will help guide you on these calls, and you'll be successful if you utilize it. As always, this video does not contain all of the required information about hypotension. Rather, it's just a guide for you to utilize to treat hypotension. This concludes the hypotension approach video.